Welcome to the Parkinson's Solutions Summit. I'm your host, Dr. Ken Charlin. I have a very exciting interview for you today with Dr. William Noah. He wears so many hats in the sleep world. He's the founder and CEO of SleepRes LLC, the medical director of Sleep Centers of Middle Tennessee. He and I were just talking. They see 17,000 patients a year for sleep evaluations across the Middle Tennessee area in their multiple centers. He is an expert, he is a researcher, he is a pioneer in the area of sleep medicine and how we can really correct this epidemic problem of sleep apnea properly. In just the few minutes we've been chatting before I hit record, he has taught me a tremendous amount. I know you're going to learn a lot. Dr. William Noah, welcome to the Parkinson's Solutions Summit.
Well, thank you for having us. When I say us, I mean, I sort of represent the whole group.
So you are at home. You described your office there as your research lab and in fact, you personally said, I haven't seen patients for a while because I'm more in the R&D area and educating other clinicians on how to best treat sleep apnea with this new emerging technology that you're developing. Tell me a little bit about how you got here.
Well, I was doing research looking at ways to increase adherence. As you know, the problem with CPAP isn't that it doesn't work. It works great. It's just hard for people to wear. And long-term, probably less than 50% wear it long-term. And over time, they just quit. So we had just completed a trial that came out in Journal of Clinical Sleep Medicine in January of 21, and where we got increased usage by considerable amount, like almost 90% at 1 year, by interacting with them more and encouraging more and troubleshooting and just doing good care over what the standard care was here in the U.S. And so I sat down one day, I wonder if there's something I can do to actually change the machines or the mask, because in general, doctors don't really know a lot about it. They understand ventilators in the ICU, but they think there's no science in the mask, and this is just CPAP. And what I found out is there's tremendous science in the mask, and there's tremendous science in PAP devices that basically engineers have done without really input from physicians for the last 20 years. And then I found out that a lot of the changes they've done to the devices have made them harder to wear, and because they didn't understand the physiology. And so I basically worked night and day for the last 3 years. 2 years ago, I brought in my own engineers who were, 30 years experience at Philips, and we released the VCOM device to sort of shock the world that, hey, you can reduce inspiratory pressure. Expiratory pressure is the therapy. We've been doing the opposite in the field for 20 years. And then we developed what we call Kairos PAP. Kairos is a Greek word. Kairos means the right time. We don't have that word in English. Kairos was used by Hippocrates in 400 BC to talk about the right time of therapy. And so therapy pressure that you need, whatever pressure you titrate to, has to be at the right time. And if you just supply that pressure towards the end of breathing out, which we call expiration, then that's really where you need it. And you can reduce the pressure, we have found, by 5 centimeters throughout the rest of the cycle for comfort and decreased side effects. So we, created the algorithm. We just completed a randomized trial in the sleep labs comparing KPAP at the same pressure setting with 5 centimeter drop, compared to CPAP. And we found that it's the exact same efficacy. In other words, for all these years, we've been giving all that extra pressure really just to cause discomfort and to cause side effects. So this is a really exciting thing. We believe so many more people will accept CPAP. We believe so many more people will use it. We know it has less side effects, particularly with what we call treatment-induced central sleep apnea. We have a study that just got accepted for that. And this is really exciting time. I travel all over the world now, and I never really thought that I'd be doing this. I was just a private practice doctor here in Nashville, where you used to be, and I never knew when I got into this and started looking that I'd find this huge hole that we could
Hmm.
fill. But I'm really excited. My main goal is to get this on the market so I can put it on our patients.
Well, sleep apnea is an epidemic, and it just by itself is associated with increased mortality. There are subtle things. When I learned a little bit about sleep medicine, like if you're on more than, I think, two or more blood pressure medicines, that right there is an indication for a sleep study, even if you're not obviously snoring or your partner hasn't noticed that you're choking or gasping for air, pausing your breathing. And so we really make a huge effort with every patient that comes in to screen them for sleep apnea. You've touched on continuous positive airway pressure, what people call CPAP. When I learned it, we used to use the term air splint because the idea was that it was essentially that the pressure was holding that upper airway open, and that was going to be enough to allow air to pass through. But what you're clearly saying is, well, that was the way we used to think about it. And now we've learned so much more that potentially you could even make someone worse. So we have to address these issues, because when we do the Parkinson Solution Summit, we're talking about sleep, we're talking about nutrition, we're talking about movement. I'll just tell you about a patient I saw yesterday waking up 6 times through the night, not getting restorative sleep. And what does that mean for their brain when they have Parkinson's? You know?
Well, you open the door for a lot of answers right there. So we make quick comment about 3 parts. We'll start with the splitting. It is true that the pressure creates force on the wall, which, as you say, splints the airway. It actually creates an alternative airway. This is kind of interesting. Like if your tongue base or your palate is where you're obstructing in your throat, until you get to high pressures, it can't push that out of the way. But it creates like a bypass around the city in the more compliant lateral folds of the throat. It actually
Mm,
opens them up, and you create this alternate airway,
mm,
which is quite interesting. But the thing I wanted to mention is, why is CPAP so much more effective than like a nerve stimulator they implant? You see the
mm,
advertisements on TV, oral appliances, and other therapies. The reason is only CPAP increases lung volume, and increasing lung volume moves down and pulls, like I'm pulling on this hose here. And as it pulls down, it stiffens the walls. So
mm,
just increasing lung volume is treatment for sleep apnea because it stiffens the walls. And when you gain weight in your belly, it pushes the lung upward and it makes the airway more floppy. So that's one key thing, that there's 2 points, and that's why CPAP's so much more effective, particularly in severe cases, or in those who have obesity, and those other treatments tend to fail in those situations. Secondly, about the frequency of it, if you have hypertension and you're on 2 drugs or more, then you're about an 80 to 85% chance of having uh, sleep apnea. If you have type 2 diabetes and your BMI is over 30, you're 88% or something really high. Is it that right? It's 83, I think it is. And then if your BMI is over 30, you have a 77% chance right there. If you have atrial fibrillation, a study from Cleveland a couple of years ago showed 80% for that. Heart failure, well, there's 2 types of sleep apnea. I mean, so, you got to look for patients with diabetes, heart disease, and hypertension. All 3 of those point between 40 to 80 something percent. All right. If you add snoring, that's 80 to 90% chance you got it. And if you
mm,
add obesity over 30, that's another 80%. So those really accelerate it. And so when people come in, they usually have what? Hypertension, diabetes, heart disease, their BMI is over 30, and they snore. Well, that means they're like 99% chance of having it. So because the probabilities are additive. So it's kind of an interesting thing, because you can diagnose them looking out the window in the parking lot, and you can see, that they're going to have it. As a sleep doctor, it's interesting. Everyone we see almost has it,
mm,
because we're a physician referred practice. So that means another specialist or primary care doctor has seen them and go, "Oh, I think you have sleep apnea." Well, guess what? They're usually right when they
Hmm.
send them. So what we need is better screening in other specialties and in primary care settings. Because if everyone I'm testing is having it, that means there's a lot out there they're not picking up. So
Oh,
that's
yeah.
what I want to throw out. Final thing about Parkinson's, you were saying, yes, sleep apnea in Parkinson's patient is a real problem because it adds to a lot of the symptoms they're already experiencing,
Hmm.
particularly when they get in later stages and they're dealing with some cognitive issues. Because when you don't sleep well and you have sleep apnea, it decreases your cognitive function. It makes you sleepier during the day, which is a side effect of some of the medications and other things. So it's really important in Parkinson's patients to screen for sleep apnea because we can make a big impact there.
Huge. We talk so much, people understand, how did this happen? Why did I get Parkinson's? Why did I get Lewy body disease? And the term that folks hear about a lot is this chronic inflammation. So whereas identifying and addressing sleep apnea plays a key role in prevention. For example, a study I came across doing some Alzheimer's research showed that untreated sleep apnea for 4.5 years in older adults put them at a 50% greater risk of developing Alzheimer's disease right then and there within 4.5 years of new onset sleep apnea. So it's so critical to identify it from a prevention perspective. But what we're also talking about, because this is the solution summit, is that when people have these diseases, by correcting that sleep disordered breathing, they're able to actually get at some of those root causes.
Absolutely. And, uh, just to make this simple, if you have Parkinson's disease and you're listening, you need to go to your doctor and you need to say, hey, do I need to be screened for sleep apnea? And screening, is a test. You can ask questions, but at the end of the answers are yes, you need a test. Do you snore? Yes, you need a test. Or is your BMI over 30? Then you need a test because you're high pretest probability already. You're near 80%. Do I have hypertension? Yes, you need a test. Do I have diabetes? Do I have heart disease? All those things need a test, and there's others to add in there. Um, I have a, I want to do something different. I have a question for you,
Mhm.
okay? Because obviously, as a sleep specialist all these years and diagnosing REM sleep behavior disorder, it's always a tough case because you have to sit down and tell them this is a precursor for Parkinson's. It's a precursor for other alpha synucleopathies, including multisystem atrophy and, of course, Lewy body dementia. My mom got Parkinson's at a late age, passed away last fall. But the thing I've been wondering for 10 years, when my mom first got it 10 or 15 years ago, I mean, she showed me this article about the vaccine, coming out. So we've been
Mm.
following this in this Austrian company because, what I have wondered is when someone gets REM behavior disorder, what if we gave them the vaccine? Would that possibly, halt off them getting Parkinson or these other sequelae? As as the expert in that area, not me, that's my question I've had for years. Can you comment on that? I want to know.
From a preclinical perspective, if we start to see the classic mood changes, REM sleep behavioral disorder, often constipation, are there opportunities to actually head things off at the pass, is what you're asking, if I understand
Yeah, yeah.
correctly. And the answer is, first of all, I think we have to, the short answer is, I think, yes. Okay. And there's several examples that I can cite for that. We certainly do have to do a lot of education. We have to get, I don't care if it's YouTube or Facebook or, TikTok or whatever, but however people are getting to information, and that's the general public, not just you and I, but we certainly have to educate our peers, our colleagues, to be thinking about these things, because it's very clear. Let me go back to something as simple, it's not simple, but as universally understood as breast cancer. Women get a mammogram every year because they understand that early detection of breast cancer can make a life or death difference. We now see that with the emerging disease modifying therapies for Alzheimer's disease, that the people who do the very best, and we're really at the beginning of that narrative with what will, what'll happen over the next several years. But even with donanemab and lecanemab, when we treat those people with mild cognitive impairment due to biomarker positive Alzheimer's, meaning they don't meet full criteria for dementia. They haven't lost their instrumental activities of daily living, but they have the amyloid, they have some tau accumulation, they have some mild cognitive impairment as demonstrated on objective testing. That early intervention has the potential to either significantly reverse, meaning up to at least 60% slowing and the rate of decline as seen in the Trailblazer study, or if you follow the work of, Dale Bredesen, Isaacson Richard Isaacson down in Florida, who recently reported using the Precivity AD2 test developed out of WashU and now a privatized company called C2N Diagnostics, that his patients who follow these lifestyle medicine programs actually have measurable biomarker reduction. And they can say they have actually cured Alzheimer's disease. So now we're talking about Parkinson's. And the key is to recognize those early signs. We're not universally doing genetic testing, and by no means is it a purely genetic disorder in most cases, but there are these become biomarkers, these become risk factors, right? And then by utilizing the currently available and emerging biomarkers, confirming that yes, the ship is headed in that direction, and then we've got to address those root causes, if you will, and that's going to be kind of individualized to a large extent because everyone's different. But at the same time, there's some universal truths like, let's immediately look at sleep, right? Let's do what we can to correct the imbalances that are leading to this REM sleep behavioral disorder, maybe comorbid sleep apnea. We've got to get at nutrient issues. We've got to get you moving your body. Interestingly, although there's not currently an FDA-approved drug that's labeled as disease modifying therapy for Parkinson's, they're on their way, but exercise is actually listed as disease modifying therapy in peer-reviewed literature, American Academy of Neurology, Michael J. Fox Foundation, and so forth.
Yeah.
It increases dopamine levels, it decreases the alpha-synuclein levels. It has major impacts on the underlying disease. So yes, I mean, I think the short answer, I'm giving you a little longer answer, but we're on our way.
Well, that's exciting. By the way, speaking of REM behavior disorder, as someone who treats it all the time, melatonin just doesn't work well. We just almost have never had a case where we really felt that it worked. Now I know it helps a lot of Parkinson's patients with other things, but we have found that we have to use clonazepam in most of these patients to control symptoms. That's just sort of a side note. As someone who treats REM behavior disorder.
Yes, I do too. I do too. But I would say here's the thing, because we're running a very integrative clinic where we want people to take a deep dive into sleep and nutrition and movement and so forth. This really dovetails in the whole idea that, by virtue of the clinic that we run, we'll have people come in and say, well, I don't even want to be on levodopa. I want to do this all naturally. And I say, well, this is like you're an expensive, magnificent, car that if you're a Porsche aficionado, you can't drive your Porsche unless it has gas in the tank, right? And so that clonazepam certainly corrects the problem fairly quickly. And then it allows us to do the other things that are more, slow medicine that take a little time, but ultimately really get at those underlying root causes.
Fascinating topic. The whole discovery of the alpha-synuclein pathophysiology to me years ago. I mean, I think it was certainly the biggest thing in parasomnias in our field, in the last 20 years, 30 years almost.
So I want to circle back around because, I can't emphasize enough to the folks watching this that sleep apnea is one of the biggest issues out there, and as common as it is, it is still vastly unrecognized, vastly unscreened for. You know, we do Epworth sleepiness scales in our office all the time. Everyone that comes in to my office, and you might disagree with this, but at the bare minimum, is going home with an overnight pulse oximeter, because we want to know what is going on with sleep, period. And I'm personally kind of grateful, even though they're not clinical devices, for things like Apple Watches that at least give us, you know, how long are you sleeping? What does your Apple Watch say about the quality of your sleep? These are superficial, non-medical screening devices, but they're out there and they're helpful, and they still allow us to they give us a jump start, and they allow us to track things. So I want to return to this whole concept of sleep apnea, because you're really, you know, developing what is the future of treatment of this problem. And you taught me a term, treatment emergent central sleep apnea, so critical because it's a departure from the traditional treatment of sleep apnea. It tells us maybe we've been doing this wrong.
Well, we have been doing a few things without complete understanding. I'll make it clear, patients have been treated therapeutically. You know, we haven't compromised therapy, but we've been given unnecessary pressure, which was leading to more discomfort and more side effects. Particularly, I think it's because pulmonologists like myself came in the field in the late 80s, early 90s when the machines came out. And, you know, we're used to ventilating everything. So we were used to higher inspiratory pressures and lower expiratory pressures, which force air into the lungs and
Mm,
increases the size of your breath. And that's great in the ICU if you're having trouble breathing. In fact, BiPAP machines revolutionized all that.
mm,
But to treat sleep apnea, it's actually physiologically backwards.
mm,
Um, when you reduce the expiratory pressure, you make the airway smaller. You
mm,
compromise the airway that you're trying to splint open. You also decrease end expiratory lung volume. You make the lung volume less, which is trying to, you know, increase and stiffen the airway.
mm,
So you're compromising the airway when you do this. So when we increase inspiratory pressure up higher, you know, well, are we opening the airway up with that? And the answer is no, it doesn't
mm.
open the airway. It actually just forces air over the obstruction we caused, you
Oh
know,
my
or
goodness.
made worse by dropping the expiratory pressure. So that's what gave me the idea. Well, we've never done this before. Maybe we could drop, you know, the inspiratory pressure and just maintain the expiratory pressure. So initially I released, you know, this little resistor that drops inspiratory pressure 2 centimeters, just to show it was harmless, that it was more
Mm,
comfortable. It actually decreased leak. It decreased these central sleep apnea as a side effect of treatment. We'll come back to that. Uh, but then really the goal was to release the Kairos PAP, the algorithm in the machine that is no longer going to be CPAP, no BiPAP. It's now going to be KPAP starting next year. And we're going to be able to treat people with the same therapy,
mm,
but letting them experience 5 centimeters less pressure through most of the respiratory cycle. Uh, you know, Kairos meaning the right time of therapy. It's a Greek word we don't have in English. And so we're supplying the therapy pressure just at that right time, sort of behind your breath, where you don't really
mm,
feel it. And then the pressure drops. Because, see, when the 7 billion people are breathing right now on the planet, they're dropping their pressure on inspiration. That's natural. And we've
mm,
been jacking it up to people, which is unnatural. And now with Kairos PAP or KPAP, we're dropping the inspiratory pressure and we're keeping it down as you cross into expiration or breathing out. And that's what makes it a more natural recoil of the lung. Um, one of the other manufacturers, the large one who's in trouble right now, you
mm,
probably guess who. Two of their reps were over here yesterday visiting my lab, and I let them breathe on it. And
mm,
they both were like, wow, you know, it's so natural. It's almost like I don't feel like I'm on CPAP. So our goal is that we know it's going to decrease side effects. We know it's more comfortable. We know it's the same therapy. Our goal is that it's going to allow many more people to tolerate it long term and then get the benefits, and improve the quality of their life.
So, and that definitely, as you said, here we have had this sort of technology, not exactly yours, but PAP in general for a long time. And we've made some reasonable efforts to get people on it, but a significant portion just can't do it. And this is going to allow people who just can't do it to finally get on and feel like these are natural breaths. I'm also curious, though, as you know, when we follow our sleep patients in the office, we get those compliance downloads, and the relatively newer machines do give us measures of whether or not there's any persistent apneic events, and we're looking for, at least again, I'm not, I'm not doing all the CMEs you're doing in sleep medicine, of course, and being a pioneer as you are, but I'm looking for an apnea rate less than 5.
Good.
I hope that's typically still good. But my point is, let's say my patient comes in, they're like, well, I'm faithful. In fact, I have two, it's an Amber Alert. We have two machines because I travel. And so I take one on the road. I keep one at home. I use it all the time. I look at their compliance report. Their apnea index is, 2, whatever, looking good. So here's my question, though. I have this tagline that is, sleep is more than a time of rest. Sleep may be more than a time of breathing, meaning that you brought up the issue, say, of memory consolidation, right? There's other things that are relevant that are critical, like detoxification of the brain during sleep through the glymphatic pathway, the release of hormones like cortisol, or not cortisol, growth hormone and testosterone for body repair, issues related to digestion and hormones. Point being is that when we treat people for sleep apnea, we're doing a lot more than making sure that they're breathing, although that's obviously the ABCs, that's critical. And I'm wondering if, even for the folks who are in fact not having significant apneas on their CPAP, do they need to be looking at KPAP? Or do you think there may be other sort of indirect benefits, even if the apnea index is corrected?
So let's talk about that real quick. The first thing to say is the downloads that come from the machines are not accurate. They can be, but how do you know? It's like the joke I make. It's like having one referee in a basketball game. If they call a foul, was it really a foul? I mean, did he touch him? How could he see from one angle? Or if he misses a foul, did it really happen? Yes, it happened. So you only have one referee. You only have a flow signal in these devices. And Robert Thomas actually had an article, I think in 22 April in Journal of Clinical Sleep Medicine, which just reminded us all what we knew 20 years ago, is that they're not accurate. We did a study back in 18 looking at the downloads, and we used to know this because we did in-labs on all these patients. And so they were being compared to the gold standard, but now they're being compared to themselves. So if they come in and their download is 5, I don't know that it's really 5, what their index is. So you touched on this, and you're right on. The key is, how do they feel? If they're feeling better, and their index is high, say it's 15 on their download, well, you still want to investigate to see if it's real. Okay. But if they're feeling better, that's the main thing. Well, if they're not feeling better and their index is 1, well, you're not through with that patient, because we don't know if 1 is right. And, are they really getting the benefit? So what you need is an independent observer. Now, the best is to put them in the lab, but that's expensive and inconvenient, but sometimes you have to. Certainly they have centrals. But, you can use a home device and let them wear that at night. And now, pulse oximetry, the photopleth signal in it actually is a sleep test, not just pulse oximetry. So, and we can help you with that in your practice, and you can have devices and put home sleep tests on patients to Number one, do a diagnosis. Okay.
Hmm.
Number two, evaluate how their therapy is going. And you have an independent observer separate from the machine. Look, I'm in this all day. I've spent all day the last 2 days arguing about AutoPAP algorithms as I'm manipulating the one in our new device next year and trying to make it better. And there's no way to really make an ultimate one unless you have an independent observer. Because
Hmm.
again, I only have a flow signal in the machine. So I'm developing in the future one where I have separate signals to where I can know that patient's treated. I'm going to put multiple referees in the game to look for those fouls. And
Hmm.
so that's where we're going. But the take home message is if the patient's not feeling better, you're not done. I don't care if they're wearing it all night, every night, they need
Hmm.
to be feeling better. And if they are feeling better and that index is high, you still need to kind of look into it a little bit. So I hope that helps explain that with CPAP. Now, you also were talking about um, other things, like if they're having central events, which so that's where we need to do some education. Us as a field need to educate non-sleep physicians on looking at these downloads. Because whenever anyone falls asleep, they're going to have a central apnea because their CO2 is going up a little bit when you go to sleep. So you're going to have a little pause. And if you're
Hmm.
having, fragmented sleep, guess what? You're going to have a lot of pauses. And so people can get confused and start an expensive workup when, a sleeping aid or something else might help them. There's a lot of things, particularly with Parkinson's patients, that we can do to improve sleep. Like, for instance, there was a study a while back looking at patients with orthostatic hypotension, and that if they sleep on their side, they tend to do better. Uh,
Hmm.
there's other data out there. In fact, I encourage everyone to Google Parkinson's and sleep.
Hmm.
And there's so much literature out there and more coming out all the time. I was really, I peeked again the other day to get ready for this. And there were whole other areas that I really I hadn't even thought
Hmm.
about, you know.
Many, we do tend to overly emphasize the movement component of Parkinson's, but there are many dimensions of Parkinson's collectively referred to as the non-motor symptoms
Yeah.
that are equally impactful and may actually, as you pointed out earlier, herald the onset of those motor symptoms and not only warrant a being addressed, but an opportunity to even potentially stop Parkinson's before it actually happens in its fullest form.
Yeah.
So
I,
for
I
sure.
I guess I didn't answer your other question. I apologize because uh, I'm very interested in Parkinson's disease for many reasons, obviously, over the years. But you asked, will KPAP, help, what we've done before? I just want to summarize. KPAP will be providing the same therapy. So once you have therapy, more pressure or whatever doesn't really matter. Once, therapy is therapy. CPAP provides therapy, Um, KPAP will be providing the same therapy, but at reduced pressure. And
Mhm.
that reduced pressure is to provide more comfort, less side effects, less gas in your belly in the morning, less leak or less force, less tightness of your mask to hold it on. Uh, Obviously, you won't have this side effect of causing these central apneic events, like we talked about. So that's really the advantage of KPAP. There will be some patients who are just used to their CPAP and they don't want anything else. And so much of comfort is what we're used to.
Mhm.
And so that's why KPAP is really going to be helpful for new patients or patients who failed CPAP and struggled because what they hated was the difference that now they're instead of breathing negative pressure, they're breathing positive pressure. And KPAP helps to make that more natural.
I mean, I'm even wondering, and this is sort of simple speculation, but I was mentioning the lymphatic system of the brain, which is our way of eliminating metabolic waste, toxins, things like that, primarily active during sleep. And, pulmonologists are really master physiologists, and how much the pressure of CPAP potentially impedes venous return from the brain to the extent that maybe there's some benefits from KPAP that we don't necessarily get from CPAP, even though CPAP certainly has, it's way better than not treating, sleep apnea, no comparison. But I'm just wondering if maybe we can see some indirect benefits from KPAP we didn't even anticipate.
So that's sort of the home run right there. You just open the door that leaders of our field are looking at, and that we're involved with another study going on. And I'll tell you about, because this is really exciting. So, as I'm sure you know, in observational studies, CPAP obviously reduces cardiovascular events. And this goes back to Marin, the Spanish study in 2005. So there's lots of observational data showing CPAP reduces cardiovascular events. But in the intention to treat randomized trials, and a randomized trial, for those listening, means, one is blindly put in one group without CPAP, one is blindly put in the group with CPAP. They obviously know they have it, but in these randomized trials, CPAP has not shown a decrease in cardiovascular events. It's been a big issue. Now, a big problem is adherence is so poor. So your treatment group sometimes is like your non-treatment group, but still, the studies are powered enough and large enough, they should show a difference. And why is that? Well, Dan Gottlieb at Harvard, and Susan Redline also there, and Sanja Jelic from Columbia University, they have been working very hard at this, and they have found that there are these biomarkers, particularly angiotensin 2, and then sorry, Ang2, and then vascular endothelial growth factor F, which is VEGF they call. So those two, they have found that at higher pressure, those biomarkers, which are associated with increased cardiovascular events, their profiles worsen. All right. Ang2 goes up, VEGF goes down, and there's others involved. So they recently went through the Ricadza trial. It was a trial looking at CPAP in patients who are revascularized, published in 2014, and they had frozen blood samples. So they went back and looked, and what they found are those at higher pressures didn't have decreased events or had increased events, and those at lower CPAP pressures, did better. So it's just early evidence. So what we're doing is, and when Dan Gottlieb got to try on KPAP last fall for the first time, the first thing he thought was, aha, maybe this would work. So we've started, working together the last few months and starting a trial where we're going to randomize patients to half CPAP, half KPAP. We're going to draw their blood before we start to look at these markers, and then we're going to look at the markers each month. Long-term users we're going to take, and we're going to see if KPAP drops those markers. Now, if it drops those markers, that would be huge. And I'm not convinced it will, because I don't know which aspect of the pressure is causing the increased markers. If it's in expiratory lung volume, but we're not dropping that. So if there's stretch in the lung doing it, they have evidence stretching an umbilical vein that it increases release of them. It's a whole new field that's just beginning, but I think it's really exciting. And so what you bring up is really fascinating, with the limbic system. I mean, is this lower pressure going to have benefits in other areas? And I think just by obviously someone in bad heart failure, the pressure helps, by decreasing preload and afterload. But in normal individuals, I wonder if the lower pressure is not only going to be more comfortable, but have other long-term benefits. So that's really I won't say million, but billion-dollar question that we're now going to be able to investigate, because now we have a way to give lower pressure and provide the same therapy, which we never had before.
Oh gosh. We expect to have at least 60,000 people participating in the Parkinson's Summit. So this is a really, really important message that, I don't have the statistic, but it's sort of analogous to the point about if you're on 2 or more blood pressure pills, if you have a diagnosis of sleep apnea, of Parkinson's or Parkinson plus syndromes or Lewy body disease, you must be screened for sleep apnea. Absolutely. And I wonder, Dr. Noah, if as we round up our interview, if you would just briefly touch on the difference for folks between those in-home evaluations versus going into the lab, because I know you've also pioneered the OSA in-home, and that really helped people through COVID. But I still imagine there's a distinction.
Right. So, an in-home test is never going to be an in-lab test. Although I will say there is a company, Onera, that's coming out with an an at-home in-home in-lab. In other words, you have the same data collection you have, but it's going to be kind of expensive because you put the sticker here, a couple of stickers here, one on the leg, and it actually creates an in-lab type test that can be
Hmm.
done in the home. Uh, but in general, you're trying to identify more of the moderate and severe patients, and home testing is very good at doing this. And
Hmm.
you could probably identify 70% of them to 80% right off the bat, in the home. The question is for those where you see central sleep apnea, not just obstructive, for those who are, quote, inconclusive, they
Hmm.
have to come in the lab or have additional nights with the home study. The point that everyone needs to understand that the home study can tell you, yes, you have it, but it cannot tell you on a single night that you don't.
Hmm.
So, and there's companies out there doing home testing that want to offer a whole solution and they don't have an in-lab available. So they're saying, oh, it's negative or it's normal. It is
Hmm.
not. It can't be. So with multiple nights, it might be able to be. Certainly, the guidelines by the academy are if you have an inconclusive, means it didn't show sleep apnea, okay, then you have to come in the lab to exclude it. And those who have a high pretest probability, those who, have a greater than 75% chance of having it, which all the things you've mentioned are over 75%. So that fits in there. So that's I hope that helps. The home tests are great. You just have to know the limitations. And it's also like this.
Hmm.
The dumber the test, the more experience the clinician has to be in interpreting it. In other words, on
Hmm.
an in lab, it's always obvious. There it is. I
Hmm.
mean, it's the gold standard. But on a home test, uh, I had a friend yesterday. I was looking at his, and his index was only 9 on his home test. And
Hmm.
you're thinking, okay, well, that's kind of inconclusive or borderline, or certainly mild. But then I looked at his desaturation, and his low desat was 83, and his mean was only 92, where his normal sat's 97. So he spent a lot of time having desat. So this particular home device wasn't picking up all of what was going on as events. You see, so that like I said, you have to look at other things, and that's just one example. There's other factors, and so when primary cares are being approached, by a home testing company, here we have the solution. Well, all they're going to do is look at the number
Hmm.
and try to make a decision. And I just would encourage everyone, if you have a single night, with a home test, it cannot tell you you don't. It can
Hmm.
only tell you you did. You'll either need multiple nights or again an in lab.
Very
I
important.
hate to repeat myself, but it's just so important because so many people are walking
Right.
around out there thinking they don't have sleep apnea when they do because of this problem.
Huge. Just curious, I know we only have a minute or two left, but we're now at the dawn of this AI revolution. And I'm wondering if some of this technology is trickling in to what you're seeing in our ability to detect and treat sleep apnea more precisely.
It is, even though we say it's AI, it's still human intervened.
Hmm.
I mean, who's programming and all that. There are now 2 programs. One uses somewhat AI that the quote Academy, American Academy of Sleep Medicine has quote certified as available to score in lab studies.
Hmm.
Now, the question is, what are we going to do about home studies? Because home studies is where we really need help, where a machine can actually pick up signals and different relations of signals that humans can't, or at least couldn't fast enough. And and so that's where there's a lot of discussion and a lot of things going on. Just recently, Samsung got FDA approval for data from their watch to diagnose sleep apnea.
Hmm.
Now, what does that mean? Samsung saying clearly that, um, this is not to replace a sleep physician or all the different, saying the right things, but it's very obvious. And I gave a talk at our meetings last week, where I was really telling the whole field, we've got to change. All these years, sleep doctors have got paid to make the diagnosis, all right,
Hmm.
to read studies, and that's going away. But that's
Hmm.
okay because the diagnosis is so apparent now. People are going to
Hmm.
walk in with data from their watch here in the future, and they're going to say, "Oh wow, look, I have sleep apnea. What do I do?" And I think it's going to push my field to focus more on therapy, like I do.
Hmm.
I don't, I'm not interested in testing. It's pretty simple. I'm interested is, can they wear it long term, and is it going to change their life? And that's where we need to go as a field. We need to focus more on outcomes and less on the diagnosis, because that's going to be made for us. The other point I do want to mention to your audience that's really important is the pill is going to be out in a couple of years. Actually, well, the end of 26.
Hmm.
The first pill for sleep apnea is going to be probably on the market based on what I know from, sort of inside, based on their, phase 3 trials,
Hmm.
and what their phase 2 trials show. And I think it's going to hit the market. And
I had
that's,
not heard of that. What is the mechanism?
well, it's sort of help makes your air, the whole key is to make your airway awake while you're asleep. If you could do that, you
Hmm.
can cure sleep apnea. And it's a combination drug. We don't have time to get into that, but they can look it up. Go to apnimed.com, APNIMED. Go to apnimed, and they're going to have the first one released, and it's gonna help a lot of people. Now, it doesn't cure severe sleep apnea. It's going to reduce it. It's going to help.
Hmm.
It might help someone on a mouthpiece who's not fixed get better. Some think it'll reduce the pressure you might need with CPAP. Who know? We won't know till it's out,
Hmm.
but it's going to have side effects. But the thing about it is, it's going to change the whole field, because primary care physicians don't really want to do CPAP. But will they want to write a pill? And so I'm wondering if this is going to change, but it's going to be similar to an oral appliance
Hmm.
or a nerve stimulator. It's going to treat the mild, maybe some moderates, but there's still going to be tons and tons and tons of people who need CPAP.
Yes, and probably more that are needed than are perhaps right now willing to use it, but hopefully with the technology you're bringing online, we'll get more into the fold. I don't know about you, but I tell folks, look, for what we have today, 2024, do something, do something. I know that the oral appliance is really only for mild obstructive sleep apnea, but I'd rather have somebody wear an oral appliance than nothing at all. You know, I don't know if that's valid or not, but I really push people to find what works for you and use it.
Well, good. I really appreciate your stance on sleep and your drive and to do that. Obviously, I appreciate what you're doing in your own field, but I really appreciate your emphasis on my field as well.
Well, Dr. William Noah, thank you so much for joining us at the Parkinson Solution Summit. I know the folks in the central Tennessee area are going to want to find their way to the sleep centers of Middle Tennessee. Uh, but the folks this is an international event. So if they want to find out more about you, your work, about KPAP, about VCOM, what are your recommendations? Where do they go? What do they do?
Well, we're very easy to find, and it's easy to remember. So for those who are looking for the best sleep care, in my opinion, in the Southeast, our team, we have multiple locations in Middle Tennessee, all around Nashville area in the suburbs. You can go to sleepcenterinfo.com. That's simple, sleepcenterinfo.com, and you'll find sleep centers in Middle Tennessee. They do telemedicine in multiple states around, for others, and they're wonderful people. I truly believe that.
Oh,
And
that's
I'm very biased. Number two, if you want to learn more about KPAP and Kairos PAP and what's coming. And there's other algorithms we have that are coming out, and we have mass technology we're going to be coming out with, and other things. You can go to sleepres.com, SLEEPRES, sleepres.com. And I think there's a link there to watch Dr. David White's webinar at the end of May, where he really announced to the whole world. Dr. White, in my opinion, is the leader of our field still after all these years. And so he covers all that in detail if you want to learn more about KPAP, sleepres.com.
Excellent. Dr. William Noah, again, thank you so much for joining us at the Parkinson's Solutions Summit. I know that people have found real value in everything that you have shared, and I hope to have you back next year.
Well, thank you, Dr. Charlotte, and congratulations on the summit.